In 1985, after much discussion and negotiation, cable TV came to Minneapolis. That opened up a new venue for getting entertainment and information into people's homes. It also provided an opportunity for community voices to be heard in a way not possible before. At that time, I was directing the maternal and child health program for the Minneapolis Health Department and saw the arrival of cable TV as a vehicle for educating the general public about the public health issues facing our community. With that vision, Al Olson, the Director of Health Education for the Minneapolis Health Department, and I started this program, a public health journal. Today, after 30 years and 600 episodes covering topics from asthma to zoonosis, the program continues. Today, we're going to mark this milestone by revisiting some of the topics that have been discussed on the show and reminiscing with just a few of the 1,000+ people who have been guests on the show over the years. It should be an interesting 30-year look back on public health in Minnesota. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ehlinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to this special hour-long edition of A Public Health Journal. On this, our 600th show, we are going to look back on some of the topics that have been featured on the show and talk with some of the former guests about what things have changed, how some issues have persisted, and what new challenges have emerged. Joining me as my first guest today is Steve Mosow. Steve was my first guest on the very first show on April 17th, 1985. At that time, he was the head of the Health Futures Institute. I wanted him, as the first person I interviewed, to talk about the future of public health and speculate about where public health was headed. Today, we'll see how accurate he was with his predictions, which I have archived on a transcript from that first episode. Unfortunately, the tape of that first show is buried in a storage box somewhere, so we won't be able to see that neither of us has aged a bit in the 30 years that have passed since that first interview.
Exactly.
Steve, welcome back to A Public Health Journal.
Oh, it's great to be back, Ed.
And I know that over 30 years you've been doing a lot of things, and I want to come back to that April 17th, 1985 visit when I asked you to come from the Health Futures Institute, which was really an organization sort of looking forward on what public health was going to be in the future, sort of like Wayne Gretzky saying we're going to skate to where the puck is going to be.
Exactly.
The Health Future Institute was sort of where's that puck going to be? And you made three predictions. You said in the next 30 years, first, individuals need to take responsibility for their health. Secondly, lines between medical care and public health would be blurred. And third, there'd be new epidemics to respond to. How accurate were you in your predictions?
Absolutely, perfectly accurate.
You really were, I have to admit. So talk a little bit about that individuals taking responsibility.
Right. During that period of time, there was, I saw the trend that we were moving into a period that eventually was called wellness. I called it health promotion. And I worked in that area to kind of push that forward, working with the Surgeon General's report and on objectives for the nation, and worked on those objectives for a number of years at the Health Futures Institute. And if you look at it today, you can see just by the growth of fitness clubs and programs on television that are directed at individual responsibility that we have moved to an era where people are concerned about their own health, they're becoming educated about their own health, they're taking actions like managing their weight, not smoking, eating healthy diets, and following good public health approaches like getting immunizations. Yeah. So,
but is there a downside to that in terms of, as individuals take more responsibility, the social responsibility for their health has been deteriorating a bit?
Right. I think that's right. There's always, for every action, there's an equal and opposite reaction. And so being concerned about community and people in the community and creating healthy communities is absolutely essential, not just individual responsibility.
Yeah. So your second prediction was that the lines between medical care and public health would become blurred.
And they have been. And one of the things I worked on I worked with the health partners and became chairman of the board at one point in my career. And I was able to help them formulate their mission statement, which was they're concerned about improving the health of their members and the community, and gradually developed programs that were more population-based. Smoking, diabetic intervention programs that were able to identify members who had diabetes and then intervene with that population, specific targeted approaches. And if you look at the health plans today, all of them have programs that are population-based and encourage individual responsibility and provide for incentives to have healthy lifestyles.
Right. And I know even the Institute of Medicine has said we need to integrate medical care and public health, and they have a whole issue with that. The last one was, you know, there will be some new epidemics, and I'm wearing my Ebola tie today. You know? So we've certainly had Ebola, and are other outbreaks that we...
Well, right. I mean, that was the period of AIDS. AIDS is still with us. We have Ebola. We've moved to an era where public health is not just community public health, it's not state public health, it's not national public health, it's global public health now, with the movement of people and the transmission of diseases, with some decline in people getting their vaccinations and immunizations. So we will always see new epidemics, but right now we're concerned the highest profile epidemic is Ebola, and we still need to be concerned about AIDS.
So what's the prediction you have for the future?
Well, there'll be new epidemics. I think that one of the real challenges is, contemporary challenges, is we need to address racism as a public health issue. Because that impacts the community, and the community impacts our health.
Right. Steve, this is great having you back. Stick around because we're going to have a little party afterwards.
All right, I'm up for a
party. You're the first guest among many, and so the next guest that we have is going to be Diane Peterson, who was the guest on a show in 1988, but she was also the most frequent guest that I've ever had. So we're going to show a little video clip of Diane Peterson, and she's going to come up and we'll have a chat. So watch this little video.
What do you mean? I need to be immunized? I thought that was kid stuff.
Well, George, whether you like it or not, you never outgrow your need for immunizations. So we're going to talk about that today on this episode of A Public Health Journal. Welcome. I'm Dr. Ed Ehlinger, and I'm your host for this series, which looks at some of the public health issues and initiatives that affects your individual health and the health of the community. Most of us were fully immunized as children, but we sometimes forget that our immunizations need to be periodically updated. We're going to talk about updating immunizations for adults on this program. And joining us in our studio today is Diane Peterson, Chief of the Section of Acute Disease Programs at the Minnesota Department of Health. Welcome to our program, Diane.
Thank you.
What are we talking about when we're talking about adults getting immunized? Are there lots of adults who need vaccinations?
Yes, there are, Ed. I think we've focused a lot in recent years on childhood immunization programs and maybe forgotten that adults need immunizations too.
Yeah, I know that we really make a big push for kids getting into school. In fact, they can't get into school unless they're immunized. But I don't see any big push on to get adults immunized. I mean, it just is kind of like a forgotten issue.
It's obviously a more difficult task. Just as you said, with children, we have rules and laws that govern their attendance in school, that they have to be immunized or in daycare, but we don't have the same kind of methods to work with adults. So we have to work through public awareness programs, such as what we're doing now, to alert adults that there are immunization needs for them as well.
Is there any estimate on how many people who are adults that need to be immunized? Any percentage?
There are. I think one of the more traditional vaccines that we have had around for a number of years with influenza, for example, which has traditionally been recommended for certain high-risk adults. Nationally, I believe the estimates of vaccination rates are about 20% of adults who need the shots actually get them. Here in Minnesota, some of the surveys we've done have shown that we fare a little bit better, but maybe only upwards to 30% of those people who need them actually get them.
Diane, thanks for being with us today. I bet you're a little surprised to see that video.
Yes, I was.
You haven't changed a bit.
Well, neither have you, Ed.
Yeah, good, thank you. But I suspect since 1988, a few things have changed in your world. I mean, you have been working on immunizations as long as I've known you. You know, back in the 80s and 70s, I mean, you were Ms. Immunization for the State Health Department and still now working with the Immunization Action Coalition. What has changed over the last 30 years in terms of vaccines and vaccine-preventable diseases?
Well, several things. One is we have more vaccines now than back in 1988. Interesting to watch the conversation about adults focusing on those with certain risk factors, because there's now several vaccines that are routinely recommended for adults. For example, influenza, it's everyone 6 months and older. Pneumococcal disease, shingles vaccine for adults over 65. So yes, and of course for young children, school-age children and young adults, there are routine vaccinations as well. The other thing, of course, that has changed is that many of these diseases have declined to remarkable achievements.
Yeah, so we've had some real successes in immunizations, and that's why I brought you back. You're the most frequent guest on this show because immunizations are such a main part of our public health armamentarium. But what have been some of the successes over the last, well, let's say the last 50 years in terms of vaccine-preventable diseases?
Okay, we can go back to the 70s then, when smallpox was actually eradicated from the world.
The first disease that really was eradicated.
Yes, total eradication. The other one that folks are focusing on is polio. And we're now down to just 2 countries in the world that has wild virus polio, but there's very aggressive efforts going on to control that as well.
So what are some of the challenges that persist? Because I know vaccines and immunization are still in the news. There are people who are resistant, and there's wondering about side effects and links to things that really have no scientific basis. But what are some of the challenges that you see?
Well, as Steve mentioned just before me too, we're really talking about a lot of global issues. So it's not just focusing on what's going on in Minnesota or even in the country, because all of these diseases are just a plane ride away if we let our vaccination levels fall. And that's a possibility too, because we have young parents today that don't remember or know of anyone that ever spent time in an iron lung because of polio, or that suffered any of the other serious consequences of these diseases. So as these diseases are eliminated or significantly lowered, we find that parents say, well, that's not a big deal.
Yeah. But we still have, you know, whooping cough, and we still have measles that come out. Why are those coming up and down periodically?
Some of them are cyclical. And others, if you have, even if you have 95% of your population vaccinated, that 5% will accumulate over time, and then it's just ripe for a virus to enter into the community and cause significant disease. We saw that with measles earlier this year with an outbreak that started in Disneyland. And you can imagine with all the travel to Disneyland over the holidays, people brought it back to their home state, and we saw a spread in those communities.
Mm-hmm. Now I also hear the term vaccine hesitancy. People are resistant to getting immunized a little bit because they've not seen the diseases, or they have religious or philosophical objections. How are you dealing with those kinds of pushbacks?
That is an issue. I think we have to build trust in the vaccines, that people are saying, you know, we have this increase in autism. And what's happening at the same time is that children are getting vaccinated, and then the diagnosis comes that they have developed autism. So we have to be able to comfort them, and we need to find what's really behind the autism issue, and to let them know that these vaccines are safe, and the consequences of not getting vaccinated are very, very serious.
Mm-hmm. And so what does the future hold? I mean, as you said, we have many more vaccines than we did in 1988. And are there new things in the pipeline, new diseases that we're going to be addressing with vaccines?
Well, there always are. And wouldn't it be nice if we had a vaccine for cancer? We actually have two already, the hepatitis B vaccine and the human papillomavirus vaccine that prevent cancers. But if we could prevent other types of cancers, that would be remarkable.
Yeah, good. Any other predictions that you have for the next 30 years? So when you come back 30 years from now, we look at...
I hope that we can come up with a cocktail or something that will address all of these vaccines and not a lot, because a lot of people comment about too many too soon, you know, and we need to do something to maybe bring them together or not to need repeated vaccinations. And I know there's a lot of work on influenza vaccines right now so that we don't have to remember every fall to go in and get that influenza vaccine.
Put them all into, a lot more into one pill or one thing, or put them into our brownies or something. So
that's right. Wouldn't that be nice?
Diane, it's great to see you, and
Nice
thanks
to
for being with us. This is, like I say, you're a frequent guest because you have some important information to share.
Well, thank you for the frequent invitations.
You're welcome. All right, so next we're going to take a look at Head Start, which is one of those major public health initiatives over the last 50 years. And in fact, this year we're celebrating the 50th anniversary of Head Start. And so I'm going to be inviting Alyce Dillon, who was a guest on the show in January of 1990, to join us. But let's first take a look at her visit on this show in 1990. Today we're going to talk about the Head Start program, a program that has helped the development of thousands of children since its inception in 1965. Joining us in our discussion today is Alyce Dillon, Executive Director of Parents and Community Action, the agency that runs Head Start in Hennepin County. Welcome to our program, Alyce.
Hi.
I appreciate you taking the time to be here. What is Head Start? I mean, what is this agency or this entity or this thing called Head Start?
Well, Head Start is largely a federal funded program that's comprehensive in nature, that provides health, education, parent involvement, social services, and a variety of other services to children and their families who come from extremely low-income backgrounds.
Why did Head Start get started?
Well, Head Start began 25 years ago as part of the Great Society programs, the Johnson administration's War on Poverty. And began as a summer initiative in some of the urban areas in the country because it was a belief that perhaps if we gave kids from less advantaged backgrounds a head start, they would do better once they got involved in the school system.
Had anything like that been done previously?
No, as a matter of fact, that was the beginning of that concept.
So that was kind of a new initiative, a new thing. It's now been around for 25 years. Has it worked?
Head Start is the most federal studied program. More studies have been done on Head Start than any other federal program in our country. And consistently, study after study has shown that Head Start provides lasting impacts on children.
Now, I mentioned in my little introduction that there's something about a program that reduces welfare dependence, that increases employability, that increases school performance. Are these the things that Head Start has been shown to do?
Yes, there have been a number of studies that show that children who have the benefit of a comprehensive preschool program will do better than their counterparts who haven't had the same experience once they get into the school system. Less likely to become teenage pregnancy cases, more likely to become employed, on average go to school at least 2 years beyond that of their parents, less likely to drop out, less likely to get involved in the juvenile justice system. And it's a very cost-effective program. $1 invested in young children now will save $7 over the long haul.
Welcome, Alyce. Good to have you back on the program.
Good to see you.
It has been a while, because I think I've only had you on the program once. But Head Start, an important program. And by the way, happy 50th birthday to Head Start.
Thank you.
And you have been part of Head Start for how long?
Actually, December 6th, 46 years.
Wow. So you were there pretty much at the beginning of Head Start. How has, in the little clip that we showed, that talked about how Head Start has been really studied, it has lots of impacts. In that 25 years since we've had that conversation, how has Head Start changed?
Well, it's become, as any federally funded program or state funded program, considerably more bureaucratic, not always for good reason in my view, but it's matured. We have many more qualifications, for example, for teaching staff, credentials, much more sophisticated relationships, community-based relationships to provide services, for example, with the health care industry. That's sort of the good news. Head Start has always enjoyed great bipartisan support. The bad news is that even though we continue to serve more and more children and get more and more support to do so, the number of children are growing. And in our own community, we started out serving 200 children. We now serve more than 2,500 children. But today in Hennepin County, without actively recruiting, there are more than 2,000 children on a waiting list as we speak.
Because that was going to be one of my questions. Is the program still necessary? And it sounds like it is more essential than ever.
Yeah, it really is, and it's changed. In the demographics of the program have changed, particularly in our community. We've had influx of Hmong refugees at one time, and it was interesting because nobody spoke Hmong. You couldn't find an interpreter to speak Hmong, and Head Start was one of the first programs that really had an impact on that community, and we sort of did the hand jive and got parents involved in the program and got them into school and training, and we're very successful with that population. Now we have a lot of people from Latin America, Mexico, Central America, a huge Somali population. So there continue to be challenges in terms of understanding, new and different cultures, language barriers, all those kinds of things.
Yeah. So what have you learned in the last 25 years from Head Start? What are the things that we're saying, this is what we need to know and we need to get out to the general community about how to deal with young children and their development and how important their development is to the economic and social well-being of our community?
Well, I think my personal opinion is a little discussed and known fact is the parent involvement that's involved in Head Start. That you can have a wonderful early childhood comprehensive services program, but once the children leave the program, they have to have some, if they're going to continue living in poverty and poor housing and economic status, it's not going to really have much lasting impact. So the important critical part about Head Start that isn't talked about as much as it should be is the fact that Head Start gets the parents involved and gives the parents power and decision-making power over the program. So they get involved with their children from a health perspective. They learn why it's important. We have an interesting program that's had a reduction in emergency room visits, for example, because many of the parents didn't even have a thermometer at home, and they don't know the difference between is this minor and the kid can just go to bed and we'll be fine tomorrow? Is this something I should take the child to the doctor for? Or do I really need to take this child to an emergency room? And so we do training, and we do it in multiple languages. We have sort of the UN kind of things, and we've managed to reduce emergency room usage not only here in Hennepin County but throughout the country in Head Start.
I know Head Start started out with 4- and 5-year-olds, and now it's even younger than that for early Head Start.
Pregnant mothers, infants, toddlers, and preschoolers.
Right, and that must be really having a bigger impact, because we know the earlier you start to intervene, the more impact you're going to have.
It's so amazing. We have infants that don't speak yet, and we teach them sign language. And they can tell you before they can even speak that they're hungry or they're wet or even say thank you. You know, it's really quite astounding.
Great. Well, it's been an astounding program. You've been an astounding leader for Head Start in Hennepin County for a long time. So thanks for your work there, and thanks for being on the show.
Thank you, Ed.
Next, we're going to really look at how a non-traditional approach to public health, theater, really impacts health. And I've had Syl Jones on the program a couple of times, and one was in 1991, talk about theater and public health. So we're going to have Syl come on, but first we're going to see a little clip of his visit in November of 1991.
Welcome to Public Health Journal, a program that brings you up-to-date information on health issues that affect you and your community. Your host is Dr. Edward Ehlinger, Director of Personal Health Services with the Minneapolis Health Department. The program is sponsored by the Minneapolis Health Department and the Hennepin County Health Department.
Welcome to a Public Health Journal. Today we're going to talk about writing and theater as a way to address public health problems. Joining us in our discussion today is Syl Jones, a communications consultant and a playwright who has had several plays produced throughout the country. Syl, welcome to our program.
Thanks.
I appreciate you taking the time to come and talk about it. And it's always kind of interesting. I have this view that public health encompasses much more than just immunizations and clinics. And you know, a lot of people wouldn't think of playwriting or writing in general as kind of a public health activity. But how do you see theater in particular being used to address kind of public health problems?
Well, I think there are lots of different ways, but one of the ways that's really intriguing to me is the whole issue of mental health and the fact that playwriting and theater can be used not only to reflect the current conditions that exist in an environment or in a community, but they can be helped to or used to improve the mental health of a community. And in my case, a lot of the writing that I do is really directed at and comes out of experiences in the African American community, and I try to affirm the feelings and the interests and the beliefs of the African American community, because it's easy to get the feeling, if you're an African American in our society, that you're going crazy. Mm-hmm. I think one of the things that theater can do is help people understand that you're not really going crazy, that this is the way it is, and can also help people do things to deal with the kinds of problems that they're having. So
it kind of reflects the community. It's a mirror to what is going on in reality.
Hopefully it's greater than that. I mean, I think that the theater, particularly as opposed to the cinema, should affect or have to do with the aspirations of people in society and should go beyond a reflection of simple reality. At least that's how I feel.
Syl, welcome to the program, and welcome back to the program.
Thank you, Ed.
I wish you'd have worn that sweater from that 1991. It would add a little bit more color to our set. But
it would have. I'm sorry, I don't even know where that sweater is today.
but thank you. And I have to reflect for the audience is that you and I started collaborating really in the early 80s when we had a problem with infant mortality, and you came to us and said, I have a thought about how to approach infant mortality, and that is to do a play.
Right.
And you did something called Baby Baby, which actually helped to change prenatal care in the Twin Cities with some of the health plans. And since that time, I think you've been engaged in a lot more activities related to theater and writing and health. Tell us a little bit about how that has evolved over the last 30 years.
Well, I began to actually do commercial theater, which would play, for example, at the Guthrie Theater and at Penumbra and Mixed Blood, for example. That's one stream. But then I started looking at ways to institutionalize theater, to bring it into organizations. So I worked with Allina Health, for example, on a play that was really about employee engagement, making sure that every employee understood that the life and death of a patient who came through the door was dependent a lot on what they did. So we created a play where we went backwards in time, and we showed that through the engagement of certain employees, they were able to save the life of of a person. And that may sound a little bit corny, but on stage it actually had a huge effect, and it changed, and Mary Brainerd talks about it to this day as something that changed the way that Health Partners thinks about art. So what we've really seen, I think, since my last appearance on your show is the integration, more of the integration of the arts within the healthcare context. And that I think is very healthy for all involved, artists, communities, as well as healthcare organizations.
I know we've been making a pitch on the public health side about a health in all policies, and that art and music and you know, plays are actually health things. Are the people on the artist side, do they understand that they really have an impact on health? Is that also understood?
No, it's not understood. In fact, there's a divide sometimes between the arts and the sciences, and you know very well academically that divide is reinforced sometimes by the way things are taught, when really at the root these things should come together. And I think when you talk to artists, they're really surprised that you mean you can actually do some work that will influence people's health. And I think there are certain visual artists who have done that. There's certain musicians who have done that, but it hasn't reached a larger artistic community. There's still a little bit of a divide, and I'm hoping that that changes. In fact, I'm working to make it change.
Yeah, I understand you are doing something called narrative medicine.
Right.
Tell me a little bit about that.
Well, I'm working at HCMC right now, teaching narrative medicine to interns and to residents. And what that really means is the use of stories to diagnose, treat, and follow up an illness. And then there's another part of it that has to do with teaching patients how to rewrite, in a sense, their illness or wellness narratives. So when people come in with chronic diseases, patients, for example, I get them involved in a process that's about really rewriting their own script so that they can start to visualize themselves as something other than chronically ill. And when you do that, there's a great deal of power that comes from actually putting down in writing or creating a film or even creating a rap song that tells a story of you as a different person. And sometimes I want to call this, I have a special name for this, I call this being the hero of your own life. So we're trying to interject these systems around narrative to help people understand how they can help themselves. At the same time, when I'm talking to residents and interns, I'm astonished to find out that they are not listening to their patients. And what I mean by that is that a patient really is interrupted in the first 13 seconds after he or she begins to talk to a physician, when really most patients only need about 2 minutes to really, of uninterrupted speaking, to tell their story. So I'm trying to teach interns and residents to listen for the story and not to be listening for all of the diagnostic indicators, for example.
Well, it's interesting. I've developed something called a triple aim of health equity. And the first aim of that triple aim is broaden our understanding about what creates health, which really means change the narrative about what creates health. And the narrative right now is that it's about medical care and personal choices, but we know that the narrative is really about the social and economic and environmental conditions in which people live.
Right.
And that story needs to get out. So how do we get that story out to the health side, public health and medical care side, but also to the artist community that they really need to work collaboratively? How do we change that broader narrative?
Well, I think there's a need to talk about why the narrative should be changed. Right now, I think what gets in the way is the money of the healthcare system. I sometimes wonder what health is really for and what the healthcare system is for. It appears to be set up as a kind of money-making vehicle for a group of people who've been specially trained, but health itself doesn't necessarily occur in those institutions. So the real thing is we need to talk about that. We need to talk about where real health occurs in the community, in the home, and in the family. I think artists can do that by telling compelling stories. But the question is, the system that we're working in, does it really want us to tell those stories? Are artists being, for example, paid and employed to do that kind of work? Fortunately, I am right now at HCMC through the Bush Foundation Fellowship that I am involved in. And so I'm trying to do this work in hopes that it will catch on and that people will actually, it will resonate with them.
Yeah. Well, I think narrative is so important that I make this pledge to you. I'm going to get you back on the show so that we can actually spend 30 minutes talking about how do we change that narrative? How do we get the collaboration between art and science in a much more collective way? Well, so thanks for all of the work that you're doing. Thanks for being on the show, and
Thank you,
stick
Ed.
around for the celebration.
Congratulations.
Thanks. Following this, we're going to talk about smoking, one of the major public health problems that we've had in our country for the last 60, 70 years. And we're going to have Kathy Harty join us. And Kathy was on the show in February of 1992 when she was working for the Minnesota Department of Health running their tobacco control program. So let's take a look at this little video of Kathy Harty's visit in 1992.
Nearly 1/3 of all adults in the United States continue to smoke. The rate is especially high among young women, people of color, blue-collar workers, and people with fewer years of education. What's being done to address this major public health issue? We'll find out on today's episode of A Public Health Journal. Welcome to A Public Health Journal. Today we're going to find out what's being done to address the single most important cause of preventable death and disease in our society, tobacco use. In particular, we're going to talk about a major new anti-smoking initiative called ASSIST, which stands for American Stop Smoking Intervention Study for Cancer Prevention. Joining us in our discussion today is Kathy Harty, the principal investigator for the ASSIST program and manager of the section for non-smoking and health at the Minnesota Department of Health, and Ralph Brower, the manager of the ASSIST program. I'd like to welcome both of you. Kathy, welcome back to our program, and Ralph, welcome for the first time. Kathy, what is the ASSIST program, this big acronym, you know, ASSIST? What does it stand for, and what is it supposed to do?
Well, ASSIST, I'm glad that you asked us here, first of all, because we do like to talk about this program and talk about why the Minnesota Department of Health received it, and how pleased we are that we were selected out of 37 states. We were one of 17 that was selected to receive it, and we're really pleased about that, especially since we've been doing smoking programs in Minnesota, and we've been very successful. We've been successful among middle-class white people. And our smoking rate is well below the 30% national average that you mentioned at the beginning of the program. However, there are certain selected target populations, those that you mentioned, that have a very high smoking rate. In addition, the cultural minorities, like American Indians, have about a 60 to 70% smoking rate. And of all the groups that you mentioned, nobody has a smoking rate less than 30-some%, and some are considerably higher. So it was real obvious that even though we've been successful in a certain segment of the population, there needs to be more done with these targeted groups. And the reason that the State Health Department was selected is because there have been a lot of studies done around smoking and tobacco use for years and years and years. There are 60,000 articles in the database. Most of those have been done with research institutions or universities. It was thought by NCI and others that it's time to get this technology, the studies, the research out into the communities, out into the real world, and that's one of the reasons why ASSIST was put together.
Okay, so this is really a public health, kind of community-oriented program to target particular groups to try to reduce their smoking rates?
That's absolutely right. And it's actually a full partnership, if you will, with the target populations, because we want to use the research that has been done, but we also want and need to involve the target communities themselves so that they can help us come up with appropriate interventions.
Kathy, welcome to the program today. Welcome back to the program after your visit many, many years ago. Talking about an issue that still is our #1 public health problem, smoking. We've been really focusing on tobacco use, at least since 1964 with the Surgeon General's report. That's now 60 years ago. And we're talking today about 30 years of this program talking about it. Why is smoking still a big problem in our society?
Well, we have made some progress. The smoking rates are lower, and as you look around you, you can see that there's no smoking in most public places, well, all public places. But the lower income targeted populations still remain a problem, nearly intractable. Part of it has to do with the tobacco companies selling loosies, which means single cigarettes. And it's also still, even with all the increases in price and taxes, a very cheap drug. Mm-hmm.
Now, you ran the ASSIST program, which we talked a little bit about on that clip in 1992, and we've had since that time the tobacco settlement, and with lots of dollars going into tobacco. So what has been shown to work in terms of reducing tobacco use?
Well, I think the main thing has been non-smoking public places, just clearing it right out of public places, getting rid of it in bars, and whoever thought it would happen in bars. And in Minnesota, we used to have separate but equal smoking and non-smoking sections. There used to be smoking in airplanes, And all of that has been
There
eliminated.
used to be smoking in hospitals.
There used to be smoking in hospitals. That's hard to believe. In fact, when I talk to my younger nieces, they can hardly believe that that actually happened. So those things have all been successful, and increasing the taxes made it unattractive to a lot of people. But there's still a group that wants to do smoking and wants to have that drug very easily attainable, much more so than alcohol or other kinds of street drugs.
Mm-hmm. So what is the tobacco industry doing to offset some of the policies and the price increases? I mean, we know that public policies like allowing no smoking in public places and increasing the taxes, those work. What is the tobacco industry doing to try to keep people hooked on this product?
Well, vaping for one thing, and that's been, I think, more successful than anyone would have thought.
So they're thinking e-cigarettes.
E-cigarettes and inhaling the nicotine directly, I think that's the main thing that they've done. They also haven't given up on lobbying. And the settlement was a really big thing, as you mentioned earlier, but all except for, as far as I know, Oklahoma, all of that has gone back into state coffers as opposed to being directed towards tobacco programs. And I think that was a really unfortunate thing, because that could have made a big difference. I mean, you have to face it, money towards programs in tobacco control really has been successful.
Mm-hmm. Do you think that we took our eye off the ball after the tobacco settlement and the Freedom to Breathe Act, where we had some real good progress made, and we said, all right, we've got this licked, and we've backed off, and the tobacco industry took advantage of our, kind of stepping back?
Yeah, I think that is absolutely true. I don't think public health people wanted that to happen, but with the settlements that were happening all over the country, the money that came from the tobacco industry, it kind of was successful for a while, but then after that, the money went away.
Mm-hmm. What about the Food and Drug Administration? They really have control of tobacco. Theoretically, they can really put some limits on it. How are they working to actually advance the reduction of tobacco use?
Well, they're trying to ban things, but a ban doesn't actually work that well. I think the Food and Drug Administration has done some good work, but by banning things, it just doesn't convince kids, especially, and young people, and people who have access to individual cigarettes and e-cigarettes. It's too much of a disconnect.
Mm-hmm. So what challenges would you give to the future generation of public health workers related to tobacco? What would be your say, this is what you need to do over the next 20 years?
Yes, that's a really good question. I wish I knew the good answer for that, but some of the things I think could be having actual programs in communities, as we did there for a while, in low-income communities especially, and minority populations, that would actually speak to them and be realistic. I think the gentleman, Syl, that you had on earlier, that could be a very good way, using art and artists and really speaking to the community, because there is a limited amount of influence a public health person can have, often seen as just preaching the same old, same old.
Yeah, good. Well, thanks for all of the work that you've done over all of the years on our #1 public health issue, tobacco. We are doing great things. We've made a lot of progress, still a lot more to be done, and that's the challenge. Our work is never done, so thanks for being with us.
Well, I think you've contributed a lot, especially in Minnesota, towards bringing all these issues out in your creative, wonderful program here.
Well, good. Thank you very much. And so our final clip that we're going to do is when we did our 500th show on September 2009. And on that show, we had Todd Munson from the Hennepin County Community Health Department, Sandy Magden, who was the Commissioner of Health at the time at the State Health Department, and John Finnegan, the Dean of the School of Public Health. Neither of those folks can be on the program today, but we're going to show this clip, and then we're going to come back with George Bowlin, excuse me, who has been part of this program almost since its inception. So let's take a look at this 500th episode back from 2009.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ehlinger, Director and Chief Health Officer of Boynton Health Service, University of Minnesota. A Public Health Journal is sponsored by the Hennepin County Human Services and Public Health Department, Boynton Health Service, the Minnesota Public Health Association, and the City of Minneapolis, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we are celebrating the taping of the 500th episode of the show. Over the last 25 years, guests on this program have talked about a myriad of public health issues, ranging from AIDS to zoonoses. They have come from throughout Minnesota and various places in our country. They have discussed data, research findings, history, programs, policies, and people that have helped shape public health in Minnesota and the country. In its own small way, this program has been part of the effort to educate the community about the role and importance of public health in our world, and to remind people that everyone needs to be part of the public health effort in our society. Today we're going to reflect on the state of public health at the national, state, and local levels. We'll examine where we have been, where we are, and where we are going. Joining me in this discussion are three leaders in the field of public health who represent important parts of our public health system. Sandy Magnan is the Commissioner of Health for the state of Minnesota. John Finnegan is the Dean of the School of Public Health. And Todd Munson is the Area Director of Hennepin County's Health Department. Thank you, all of you, for being on this program.
Thank you.
And I know each of you deserves a program all on your own, and I hope to get you to talk about, because, I mean, the School of Public Health, the State Health Department, the Hennepin County's effort, yes, and it needs to be done over and over. But we're going to kind of take some time and sort of reflect on public health. And one of the things that I'm not going to do is I'm not going to show clips from back in 1985, because I had a lot more hair and fewer pounds, and I was a little bit more limber, and I'm no smarter today than I was back then.
Oh, that's
so,
not true.
And denial is not just a river nap.
That's right. Yeah. But one of the things on our first program in 1985, on April 17th, 1985, we talked about sort of predicting what the future of public health would be. And the three things came out: that in the future, individuals would need to take responsibility for their health. There'd be a blurring of the lines between medical care and public health. And we would be responding to new epidemics and new toxins. How have the issues changed how the school has changed?
And I've been there during all of those 25 years, so I've seen a lot of that change. When I talk about this, we talk about public health as, and maybe this will predict the next 25 years of public health, it's collaborative, it's interdisciplinary, it's interprofessional, which I think talks about that blurring, it's global, and it's digital. And I would say certainly everything that's happened over the last 25 years, we've seen that happen with public health. And it's had a huge impact as far as my school is concerned, which is part of the Minnesota public health system. For one, we've seen, I think, an increase in public interest and student interest in public health as a profession like we've never seen before. Back in the 80s, you know, we had maybe 350, 360 students. Right now we have 1,360 students in the School of Public Health. And I think that's reflective, of course, of the excellence of the Minnesota, University of Minnesota, but I think it's also very reflective of what has happened over the last 25 years as far as public consciousness and awareness of public health, whether it's chronic disease, whether it's infectious disease, whether it's health care and health systems and public health systems.
Welcome, George. Glad to see you on this side of the camera, because for the people who have been watching this program for maybe 30 years, you've been on the other side of the camera for most of this, and you're one of the people who has been involved with this program almost from the first episode. I think you came on after 3 or 4 episodes because the county wanted to get involved. And so we're not going to talk about the issues here, but we're going to talk about this program. This is going to be the little reminiscing part. So I want to ask, why did the county want to get involved in this effort?
Well, you had, and Al Olson, this vision of where we might be able to take public health and using television or cable television to communicate that. And the county was real open to that. I think they bought into that real early on, and it wasn't a difficult sell with leadership at the county. And I was interested in doing it, and the director at the department was very supportive of that, and so we stepped right in there and we're delighted to partner with the city of Minneapolis.
And why has the county continued, even to this day? Now, 30 years later, the county is still a major supporter of this program and really an integral part of what we do.
I think the county felt like the show and the use of cable television held great promise, and during the 30 years, that's been borne out. And the community has responded, whether it be people eager to be on as a guest, or people, agencies, organizations requesting copy of taped shows so that they could use them. Good example were school districts. So I think the county recognized the real potential for this, and that's been borne out.
Yeah, and I'm going to ask you sort of some of the things that were highlights in your years with this program, but one of the highlights, and we've got a little piece of videotape about this, one of the highlights has always been the fact that prior to the beginning of the show, you had the responsibility for making my increasingly large forehead a little bit less shiny. Tell me about, was that job enrichment, or was that hazardous duty pay?
Oh, it was job enrichment, and we certainly had a lot of fun over the years with that. But it was necessary, and
yes, it definitely was necessary.
You cover the real estate, and anyway, it was just part of the job.
Yeah, good. Yeah, you have to have a little bit of fun. I always say if it's not fun, it's not public health, and so this program certainly has been fun. What are some of the highlights for you of the years that you've had, the 30 years you had with this program?
Well, certainly the broad definition of public health and what we brought to people's awareness and understanding of public health would be a highlight. Personally, great opportunity to work with you and others that were involved in the show, and to meet people, whether it was at the local level or the state level, federal level, and in a few instances the international level, that were the leaders in public health, people that had a great deal to say and were major contributors to the public health.
We had 5 different guests prior to this that really are sort of they are leaders in public health, have been leaders in public health for a long time. Any other names pop up that of the people we've been on that people should sort of remember?
Well, there certainly were some memorable people on that maybe were under the radar, so to speak, in public health. Mercury Man, for one, comes to mind.
He's still around doing other things?
I'm certain that there are, but that was one show I think that was great fun. We had commissioners, the current seat that you occupy, and these were people that really helped shape the agenda in this state. We had people that worked in the trenches that were so dedicated, so committed to public health, and this show was an opportunity for them to really talk to a larger audience in some instances about the good work that they were doing. So it was a celebration, if you will, at times of the fine work that they had done.
Mm-hmm. And when we were talking to Diane Peterson, she's been the most frequent guest on this, and so we've really tracked immunizations over the years. But the other person who almost matched that level was Bruce Taylor from the Minneapolis Health Department, and it was because he was the AIDS educator, and that because AIDS was a huge issue in the mid-'80s and stayed on for many years as a high priority thing. How did you see the transition and this program actually educating the general public about HIV and AIDS?
Well, I think that there were certainly a couple of transitions. One was very much the sort of technical transition that we had from a very basic level kind of operating studio to now a very nice full-fledged television studio. But also the transition, I think, occurred among the guests who recognized that this was a powerful method or an approach to educating people and raising awareness, and in many instances I think changing values that people held about not only the benefit of this technology but also about their values associated with the particular problem that we were addressing, whether it be AIDS or infectious disease of some sort.
Yeah, good. Well, George, like I say, you have been an integral part of this program, and whatever success we've had, it really is, a lot of it is due to your work, your persistence, the quality that you brought to the work. So thank you for all of that, and I appreciate that.
Been a pleasure working with you too, Ed.
All right, now before we have a little celebration, I need to do a little closing comment. So let me remind you that a great deal has happened in the field of public health over the last 30 years. Some of those changes have been positive, while some have not. We have controlled some diseases with vaccinations and antibiotics, and we've seen improvements in heart disease due to medical advances and lifestyle changes. But we've also seen the risk of new diseases like AIDS, Ebola, Hepatitis C, and Alzheimer's. We've also seen an explosion of some diseases like diabetes and mental illness. We've seen major improvements in the quality of our physical environment, but that environment is now threatened by significant changes in our climate. Similarly, we've improved the safety of our food and water, but that status is also at risk because of some of our agricultural and food distribution practices. Now, if you just look at the major numbers of our health indicators that we use, like life expectancy and infant mortality, it would appear that we have made some great progress in public health. For example, in 1985, life expectancy at birth in the United States was 74 years. Today it is 79 years. The infant mortality rate has been cut in half, 10.6 in 1985 to 5.2 today. However, compared to the rest of the developed world, we are not doing well. We are now 34th in both life expectancy and infant mortality. 30 years ago, we were in the top 10 in both. In addition, we have some of the world's greatest disparities in the health of whites compared to the people of color and American Indians. Among the reasons we are falling behind is because over the last 30 years, we have diverted our attention from public health and focused most of our investments on medical care. We have taken a biomedical approach to health and have relied on medical care to treat us into health. Yet, we are slowly realizing that medical care only determines about 10% of our overall health. What really determines our health is the social, economic, and physical conditions in which people live. The conditions that can be positively affected by a public health approach. So as we look forward to the next 30 years, I hope we come back to the realization of the truth of the old adage that an ounce of prevention is worth a pound of cure. That investment in public health is the only way we'll be able to improve the overall health of our society and decrease the disparities that threaten the health of everyone. We need to focus on the conditions in which people live, work, learn, and play, because that is what will create health for all of us. Public health is the way to do that, because public health is what we, as a society, do collectively to assure the conditions in which all people can be healthy. That means all of us working collectively on the conditions in our communities, like housing, transportation, education, economic development, and many more that help create health. That is our challenge for the next 30 years. I hope you are ready to take it on. So 30 years from now, when we have our 1,000, 1,200 programs, we're all back together talking about all the progress we've made. Thanks for joining us. I hope you can join us again on a Public Health Journal. Now let's celebrate with a little bit of cake.
Yay!
Yeah. Y'all get out my kazoo.
And many more.
Thank you all for joining us. This is great.